All right, good afternoon, and thank you all for joining us. I have 12:03, so I think we can go ahead and get started. First of all, if this is your first time joining us, thank you and welcome to the Fairfax County Health Department's Communicable Disease and COVID-19 updates for long-term care facility partners. My name is Samantha Christensen, and I'm the HAI Epidemiologist here at Fairfax County. Today for our outline, we have a COVID-19 situational update where we'll talk about not only COVID nationally across the states near us in Fairfax County and in our long-term care facilities, but also we'll look at the CDC community transmission levels, the BA.2.12 variant, and the BA.4 and BA.5 variants internationally. We'll also provide an update on the up-to-date definition as this changed on March 24th, and we'll go into a hot topic about symptom screening. Finally, we'll conclude our meeting with a Q&A session. So if you have questions throughout the presentation, please put them in the chat, and we'll open the floor at the end for questions. So first, we'll start off with our COVID-19 situational updates. Across the country, COVID-19 rates have witnessed a sizable increase. On this chart, we have the May transmission level, so when we met last month, and the transmission level for June, which you can see on the left. From April to May, the counties at a high level of transmission had doubled. That was from 458 to 1019. And now from May to June, they've doubled again from 1019 to 2142. The quantity of counties in the substantial, moderate, and low levels of transmission have decreased, which is reflective of the case rates rising in these counties due to higher levels of transmission. Overall, 2/3 of counties in the United States have met the high level of transmission, with counties at lower rates of transmission localized in the Midwest. Fairfax County is currently one of the 2,142 counties at a high level of transmission across the country. At a regional level, Virginia has experienced 241.6 cases per 100,000 people within the past 7 days, which is a 70% increase from when we last met in May. This rate is higher than our neighbors in DC and Maryland, with case rates of 286.6 and 259 cases per 100,000 in the past week, respectively. You can see them listed there on the right, closer to the top, with those case rates higher than Virginia. Moving to the bottom, the states that are near us with rates that are lower than Virginia include West Virginia, Kentucky, Tennessee, and North Carolina, which are experiencing rates of 207.7, 90.8, 119.6, and 114.8 cases per 100,000 people within the past 7 days, respectively. Overall, the US average rests at a rate slightly lower than what we're seeing here in Virginia at 222.9 cases per 100,000 people over the past week, which is an increase from when we last met. Over the past month, Fairfax County has experienced kind of a steady increase in the quantity of COVID cases in the community. However, recent trends show case rates beginning to plateau and potentially fall during the most recent dates of data collection. Reflecting back on 2021, during this time last year, the 7-day rolling average for cases was 20 cases per day. Now the 7-day rolling average is at 476 cases per day. The recent surge in cases, it may be due to a combination of waning immunity, relaxed mitigation efforts, and an increase in the transmissibility of the current viral strain. One thing that we wanted to also include in this update was a mention of wastewater surveillance, which has been a avenue for us to kind of monitor COVID in the community, given the increased rate of home tests that are being utilized by the community at large. So this is data that is provided by VDH. VDH has, they started monitoring their COVID wastewater surveillance in September of 2021, and this program detects the viral RNA for SARS-CoV-2 in wastewater across the state. This graph shows the daily COVID-19 cases that they have been able to kind of identify through their wastewater surveillance. And on the right-hand side, we can see the site-specific percentiles for viral RNA across northern region facilities. So the portion at the bottom here shows the percentile of RNA for viral SARS-CoV-2 that has been found in these different areas across the northern region of the state. And essentially, as this number continues to increase, they have that marked in red. So the higher the viral load that they're finding in the water is, the deeper the red color will get. The less that they're finding, the more blue it will appear. Over the past 7 weeks, we've seen an increase across all of the northern wastewater surveillance sites, so that the higher percentages are now what is most current for the northern region. Additionally, when looking at our long-term care facilities in the state of Virginia overall, VDH has reported that there were 77 long-term care facility outbreaks associated with COVID-19 within the past 30 days. This is marked by 18 in the eastern region of the state, 22 in the central region of the state, 16 in the northwest region, 11 in our northern region, and 10 in the southwest region. Staff and resident cases, additionally, looking at the chart on the right, have begun to increase. You can see they monitored the confirmed resident cases in orange and the confirmed staff cases in blue. And we have that big spike back from our winter months that had decreased down throughout March and April, but has now, since May, kind of made an increase back up. In Fairfax County specifically for our long-term care facilities, we have the case rates circled right now on the bottom right-hand side. And this chart shows over the past year the case rates for our long-term care facilities in the county. This time last year is highlighted with the arrow on the far side on the left. So this chart monitors essentially the case rates that we had last summer, which were very low, the slight bump we experienced in the fall of 2021, I'm sorry, the increase, that big spike throughout the winter of 2022, a lull again through March, and then kind of picking back up through May and now into June. One piece of interesting and exciting news is that our long-term care facility hospitalizations and deaths that we have seen have not matched the case level that we've experienced in the county. And this is largely, you can see it here in this chart. So at the left-hand side, we have in red circled the amount of hospitalizations at the top and the amount of deaths at the top during that first wave of the pandemic. So the very early spring of 2020 months. The first arrow that you can see kind of in the middle is when vaccine became available to our long-term care facility partners. And you can see the hospitalizations and deaths at that point, because it was during the winter of 2021, were still marginally higher than before, but not as high as they were in the spring. Finally, now looking at our current case rates with the arrow on the far right, you can see the hospitalization rates and death rates are much, much lower, even considering the higher case rate across our long-term care facility partners. And this is even considering that at the end of May of this year, the US marked 1 million deaths due to COVID-19. Currently across Fairfax County, there are 8 different SNFs that are experiencing COVID outbreaks. This is an increase from 2 from when we last met. Our Fairfax County ALFs are experiencing 14 COVID outbreaks, which is an increase from 8 when we last met. And we do have one group home that is also experiencing a COVID-19 outbreak. Overall, Fairfax is monitoring 1 or more COVID cases in 28 different long-term care facilities across the county, which is an increase of 10 from last time we met. Next, we'll move on to discuss the CDC's transmission levels. So the CDC has 2 different forms of transmission levels that they utilize, one for the general population and one for our long-term care facilities. And the COVID data tracker that they have on their website can be utilized to access and review these metrics at any time. It's really important to know where to find this information, because a lot of the guidance that is put out is based on for our long-term care facilities is based on what level of community transmission the county is currently in. And so to assist with helping find that information, because it's not exactly as public or as easy to find as the recommendations for the general public are, I'm going to give a brief demonstration showing you how to find exactly our COVID transmission levels for Fairfax County. Okay. So what I've done here is I have just navigated to the CDC website. This is their cdc.gov website. www.cdc.gov gets pretty easy, can't get harder than that. And what I've done is I've gone to the their index for healthcare topics, and I've picked on COVID-19. From here, I'm going to want to look at their cases and data tab. Their cases and data tab will take us over to the basically their data tracker for all of their COVID information. And what I'll do is I'll just click on this banner here to go to our COVID-19 community levels. And it'll pull up a country view to kind of show us what's going on across the United States. And you'll see levels here once it finishes loading that are broken into 3 sections with kind of a low, medium, and high based off of hospitalizations across the country. So here you can see the COVID-19 community levels for the general population. And they're even color-coded a bit different than the community levels that we use for our population. So in order to find what we are currently experiencing in Fairfax County, first, I'll change this to, instead of COVID-19 community levels, I'll move to community transmission. The difference between these data sets is that the community levels with this high, medium, and low are based off of severe outcomes such as hospitalization, whereas the community transmission here with our high, substantial, moderate, and low levels is based off of viral spread in the community, which is more impactful for our long-term care facilities at large. Now, you'll see we have a much different map, which is also the map that you saw at the beginning of this presentation, looking at the rates across the country. Now, if I would like to look at Fairfax County, for example, I have a couple of options. And the first is that I can just simply zoom in on the map and drag it over to our county. We can see here, Fairfax County, our transmission level is high. Alternatively, you can use the sections up here to select a state. So I'll select Virginia. And you can also select the county that we're in. You'll note that this section does have options for Fairfax City and Fairfax County. As a collective, we use the Fairfax County option to monitor the transmission level. Now, one thing that's important to note here as well is that when this data populates up here, by default, it will populate with the settings with the data that's utilized for the general population and not what's used for long-term care. However, if we scroll down, you can see that we are still in that high level of transmission that's highlighted here. Additionally, for your kind of ease as you are utilizing these transmission levels, we've added a link directly to the COVID data tracker in this presentation so that once the slides are shared at the end of this presentation, you can utilize that link to visit the website. Now we'll move into a discussion on the BA.2.12.1 sublineage updates. And one thing to consider when we're talking about variants of the Omicron virus is to keep in mind that emerging variants can really alter our future trajectories of the pandemic. And this is because they ultimately can increase transmissibility. They may increase severity, which could result in more hospitalizations and deaths. And they could limit the immunity that's provided by prior infection or by vaccinations. And currently our genomic surveillance, it remains limited. So this challenges our ability to kind of estimate the impact of a strain in the US to date. and estimate the arrival of new variants to the population, as well as kind of predicting what this impact could have in the future. What I've done here is I've taken the chart of the predominant variant from April and compared it to our chart from May. And this data is from the end of April on the right and the end of May on the left. And what you'll note here is that at the end of April, the BA.2.12 variant was at about 31.9% of the total sequenced specimens in region 3, which makes up Virginia, Maryland, and up to Pennsylvania, with the predominant strain still being the BA.2 variant, which was at 65.2% of sequenced specimens at the end of April. Now what we're seeing is that the predominant strain is the BA.2.12 variant, at 67.9%, and BA.2 is no longer the predominant strain, with only 28.7% of sequenced specimens identifying this variant. Additionally, looking at Virginia compared to the rest of the United States, we can see the BA.2.12 variant in this kind of lime green color, the BA.2 variant in that darker green color, the BA.1.1 variant in that light blue color, and the BA.1 variant in that dark blue color. And this chart compares over time at the x-axis the prevalence of each variant in the community, both on the right in the United States and on the left in Virginia. So what we are seeing with this kind of graph and comparison is that the rate at which the BA.2.12 variant is circulating in Virginia is a bit higher of a rate than what we're seeing in the United States overall, with about 50% prevalence in Virginia by early May, whereas only about 40% of prevalence of the BA.2.12 variant across the United States in May. Now we'll also give a brief discussion about the BA.4 and BA.5 variants internationally. And you may have heard of these. They're prevalent in South Africa and Portugal right now, but they're also sort of spreading and taking root in England, notably. On the right-hand side here, we have a chart that shows the proportion sequence cases in England that are of the BA.4 strain, the BA.5 strain, and the BA.2.12 strain. Notably, the BA.4 and BA.5 are really common in South Africa, and they have had some impact on the hospitalization and death rates in Portugal. But in the United States, our predominant strain is the BA.2.12 variant here. And we can see kind of the speed at which they are moving across England and taking root in their populations. In May, the Omicron BA.4 and BA.5 variants were classified as variants of concern. Now, UVA has a modeling projection that they update on a biweekly basis. And this is their current modeling projection for the upcoming summer months and a little bit into the winter months as well. Taking this step by step, I wanted to talk about the best fit lines for their predictions as how COVID might impact the community moving forward. And I'll start off with their blue line here called their adaptive line. This is the trajectory that is based on conditions that are similar to what we've experienced in the past and what we could expect with some immune escape due to Omicron. The blue line shows what we could expect moving into the fall months and through into the winter as well. Now the adaptive BA.2.12 line, which is, I'm going to skip the yellow one and go to the green one. This is the projection for the BA.2.12 variant on its own. So this means that we're accounting for transmission rates that are 30% higher than the BA.2 variant. And we're accounting for prevalence of the BA.2.12 variant reaching 50% on June 1st, which it has done, and reaching to 95% 4 weeks after. So that's currently what that green line is looking at. Now, jumping back to the yellow line, all of the assumptions with the green line and the yellow line are the same, except the yellow line includes some increased control measures by the standard population. So if the general population were to, utilize efforts to mitigate or reduce this transmission, then we could see it following the yellow line instead, where we have less of a spike and more of a dramatic downward curve before the fall of 2022. Finally, the red line in their model shows what could happen if the BA.4 variant becomes the most prevalent strain in the population. So this could see a bit of a higher immune escape from previous infections due to Omicron, but this is a speculative projection with the BA.4 variant reaching about 50% of prevalence by October 1st. Next, we wanted to give you guys a brief update on the up-to-date definition change that was released by CDC. So on May 24th, CDC updated their definition for up-to-date. And now it means that for adults aged 50 years or older, a second booster dose is now recommended and required to meet that up-to-date definition. So the second booster dose should be provided after 4 months of the first booster dose. And that's for all vaccine types. So if your primary series was Pfizer, Moderna, or Johnson & Johnson, this recommendation remains the same. So you would have your first booster dose afterwards, and then 4 months after that first booster dose, a second booster dose is now required to meet that up-to-date definition. And you can look at the CDC website here, with which we've included at the bottom as a quick link to kind of reference their recommendations when it comes to vaccination for different populations. Now, with this change in guidance, this means that staff members who are not up to date will need to be tested according to the community transmission level as seen before. So we wanted to put this in here as a brief reminder as to what that looks like, especially considering the new guidance. So with the adjustment of the up-to-date on vaccine recommendation, those who are staff members in your facility with a single booster dose above the age of 50 that have not yet had a second booster dose will need to fall into these minimum testing frequency requirements. So for example, if you have a environmental services worker in your facility who is 56 and they have had one booster dose more than 4 months ago, then they would need to be tested twice a week because Fairfax County is in a high level of transmission until they were able to get that second dose. Once they have that second booster dose, they would not need to be tested according to these recommendations. And anyone in your facility who does meet that up-to-date definition does not need to be tested according to these recommendations. Additionally, because this is it's a pretty sizable change in CDC guidance, we did want to offer and make mention of our medically fragile task force. This is a task force that will go out to your facility and provide vaccinations to facility residents who are not, up to date or maybe who have difficulty obtaining vaccine. Our point of contact I've listed here, that's Matthew Fondon. His email address is here as well. And essentially, if you do need vaccine for your residents in your facility, you can reach out to Matthew and who will respond with a spreadsheet where you can fill out some of the information that they might need to start to process the request and make sure that they have everything for the residents on site that they'll be vaccinating. You can see a little image here that I've put in that shows kind of what the spreadsheet will look like. Next, because this up-to-date guidance does kind of reflect the work restrictions for healthcare personnel, we did want to touch on that here as well. So for your staff members in your facility, as a brief reminder, your healthcare personnel encompasses all staff in your facility, regardless of if they have contact with residents needing care. So this means that your nursing staff, your administrative staff, your environmental services staff, they all count under healthcare personnel for your facility. So when someone in your facility, when a staff member in your facility has a SARS-CoV-2 infection, regardless of their up-to-date or not up-to-date, the conventional method is for them to isolate at home for 10 days or 7 days with a negative test. Now, CDC has provided some different levels of work restrictions based off of the difficulty of staffing in your facility. Especially last winter, we saw many facilities that had times where they struggled with maintaining standard operations due to the quantity of staff who were sick. So CDC has responded to this because it was a concern across the country with providing different levels. So the conventional level is always going to be the default for us. That will be what we that's our standard of practice. The contingency level is something that we can explore if there are difficulties with staffing levels in your facility that might be circumnavigated by not utilizing the conventional method. And finally, the crisis level of work restriction is reserved for absolute emergency situations. And you'll notice that as we walk through these, this crisis level does have the least amount of restrictions, sort of in response to the necessity of keeping the facility afloat. So for your conventional method, any staff member in your facility, regardless of their vaccination status, will need to isolate if they test positive for COVID-19 for 10 days or 7 days with a negative test. Now, at that contingency level, if your facility needs to move over there, we do request that you have a conversation with your liaison and therefore also potentially with Fairfax County at the health department here. At the contingency level, staff members with a positive test can be out for 5 days and return with or without a negative test, as long as they have improving symptoms. In a crisis mode, there is no work restriction for staff who test positive for COVID-19. However, this is, again, a very emergency situation and something in which they would be required to wear full PPE throughout the extent of their working hours. Now, for exposures for your staff members in your facility, we have an up-to-date category and a non-up-to-date category, and the work restrictions will differ based off of whether or not they are up-to-date. So if you have someone who has been exposed to COVID-19 in your facility who is up-to-date on their vaccine, through the conventional method, there are no work restrictions, with negative tests required on days 1 and 5 through 7. Now, if they are not up to date and they're exposed to someone with COVID-19, the recommendation is instead to have them quarantine at home for 10 days or for 7 days with a negative test. At a contingency level, some of this changes a little bit. So if someone is completely up to date on vaccine in your facility and they've been exposed to someone with COVID-19, both at the contingency and crisis levels, there is no work restriction for them, and they can work normally throughout your facility. However, if they are not up to date on vaccine, at the contingency level, there is no work restriction, but negative tests are required on days 1, 2, 3, and 5 through 7. Finally, at a crisis mode for your staff members who are not up to date but have been exposed to someone with SARS-CoV-2, there are no work restrictions, but the recommendation is to test where possible. Next, we also wanted to touch on isolation for your residents. And resident isolation has not changed throughout the pandemic. So this means that any resident who tests positive for SARS-CoV-2 in your facility must remain in isolation for 10 days. And this is regardless of symptoms, vaccination status, or if they're immunocompromised or not. And unlike facility staff, there is not an option to shorten the duration of isolation with a negative test. So while you might have seen on the previous slide, staff members could leave isolation after 7 days with a negative test, that contingency does not exist for residents. It must be a full 10 days. We also briefly wanted to touch on resident quarantine because now that the up-to-date definition has changed, and most, if not all, residents in your facilities will be 50 or plus, 50 years old or over. We wanted to kind of emphasize the difference between when they need to quarantine and when they do not need to quarantine. So for residents in your facility, if they are symptomatic regardless of their vaccination status, they need to quarantine in their rooms. Exposed residents who are not up to date on vaccination also need to quarantine. And then new admissions and readmissions to your facility who are not up to date on vaccination will also need to quarantine. Now, those who do not need to quarantine are those who are exposed to COVID-19, but who are up to date on vaccination. So this means that residents who have received their primary series and 2 booster doses will not need to quarantine if they are exposed to someone who's positive for SARS-CoV-2. Exposed residents who have recovered from COVID-19 within the past 90 days do also not need to quarantine during that period. New admissions and readmissions who are up to date on vaccination similarly do not need to quarantine. And then of course, if a resident has not been exposed or is asymptomatic, they do not need to quarantine in your facility. Now, when it comes time to end quarantine, residents may be removed from quarantine after 10 days if they do not develop symptoms, or after 7 days if they do not develop symptoms and a viral test is negative. Keep in mind the difference between this quarantine and isolation is that for isolation, a resident would have tested positive for COVID-19, whereas in quarantine, they might have had an exposure or similar symptoms, but they did not test positive for COVID-19. In ending quarantine, all specimens for tests required to end that quarantine should be collected within 48 hours of the planned quarantine end. And the date of the exposure counts as day 0 when measuring your length of your quarantine period. So this means that if a resident was exposed on June 1st, their last day of quarantine would then be June 11th, and they could rejoin the rest of the population, the rest of your community on June 12th. Next, we'll move into a hot topic on symptom screening. Symptom screening is something that we wanted to discuss at large with the population because we've just gone through some of the spring months and we're moving into the summer, and symptom screening is something that many facilities are very used to at this point. It's become almost a routine for a lot of us, honestly. And we wanted to emphasize how important symptom screening can be for your community because it can really stop the spread of COVID-19 because it allows us to have this early detection methodology for potentially infected individuals. And by excluding those people who screen positive early, we can ensure that like COVID does not enter your facility and it's not able to take root across your population. Now, we did want to mention that CMS does have some requirements for symptom screening, and that's that screening must be conducted for every individual, regardless of their reason for entering a long-term care facility. This means any staff members, visitors, contractors, anyone who enters the facility needs to be screened upon entry. The only exception that they have listed for this is for EMS workers who are responding to an urgent medical need. We would never pause them and have them screened before they enter. But for all other instances, the recommendation is to have them screened. Additionally, all accessible entrances need to have some sort of screening station. That way you're able to capture people who are entering your facility and coming into your community. And not only checking for symptoms, but also ensuring that a temperature check is available is important to make sure we have thorough screening. Residents in your community should be assessed for symptoms at least daily based off of these recommendations. I have seen some facilities where they will instead check for symptoms upon rotation of staff, which might be every 8 hours, but just ensuring that you're working with your residents, that you're touching base with them to make sure that they're feeling okay is really helpful for reducing spread in your community as well. Additionally, for our partners who are regulated by CMS, CMS may ask for staff check-ins and screening logs to ensure that 100% staff compliance with screening. So it's always a good idea to have your bases covered. Now, when you're screening for visitors, it's important to cover a couple key points. So even if a visitor has met the community criteria to discontinue isolation or quarantine, visitors should not visit if they have had a positive viral test for SARS-CoV-2, symptoms of COVID, or close contact with someone with a SARS-CoV-2 infection. And I'll mention here as well that one thing that we've definitely seen across the community is that some people who are recovering from COVID-19, visitors who want to visit loved ones in your facility, might be following general population guidance, in which case they are typically free at day 5 to kind of, re-enter the population as long as they wear masks appropriately. However, that does not apply to them visiting in a long-term care facility. So at your facility, even if someone is on day 6 or day 10 or day 8, they should not enter your community until they have passed day 10. And visitors, again, with any of these conditions should not visit until 10 days have passed since their exposure. So if they are developing symptoms, if they've had contact with someone with COVID-19 infection, we would ask that they wait for 10 days until they come and visit your community. Now, there are also key symptoms for us to kind of keep an eye on when it comes to people who are coming and going from your community. And it's important to keep in mind that these symptoms may appear anywhere from 2 to 14 days after an exposure to the virus. So they could have had an exposure event a week ago, and then might develop symptoms due to that at that period later. So these symptoms are things like our fever or chills, cough, shortness of breath, fatigue, muscle or body aches, headache, the very popular loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, or diarrhea. And one thing that's really important to consider with these symptoms is that many of them can be easily confused with your typical allergy symptoms. In fact, we've had instances in the community where a staff member or a visitor may have just stated that they had allergies and it wasn't a big deal, but then that could have caused transmission throughout the population when they later test positive. I additionally wanted to include this study that was released by the Imperial College of London, where they took symptom data from its 2,789 PCR positive BA.1 variant cases and compared them with symptoms experienced by over 3,000 PCR positive BA.2 cases. And the big takeaway here is that symptoms are kind of changing as we have different variants that are circulating in the population. So they found that when they were comparing these two Omicron variants, BA.2 was positively associated with symptoms like chest pain, severe fatigue, runny nose, muscle aches, sneezing, fever, chills, tiredness, blocked nose, and headache. All of those symptoms that you can see here listed in red in the chart on the right. When compared to variants at large, BA.2 was further associated with things like sore eyes, appetite loss, and new and persistent cough. These symptoms here are important to kind of describe because they characterize a different presentation than what we may be familiar with from our other experience with variants. Noticeably here, shortness of breath, sore throat, and loss of taste or smell were not positively associated with the BA.2 variant. So this is kind of a heads up to identify that symptoms that we are used to identifying or associating with COVID may be different than what we're seeing currently with the strains that are circulating in the population. One thing that you can do to improve screening in your facility is to ask about potential exposures. So here we've listed 3 questions that can kind of encompass some potential risk factors that visitors or staff members entering your facility might have experienced recently. The first is, in the last 2 weeks, have you been in close contact with someone who has COVID-19? And one thing that we've definitely seen across the pandemic, but recently, more frequently, is that you might have a staff member in your facility or a visitor who might be visiting a parent who has a child at home who is tested positive for COVID-19. And being a frequent caretaker for a child who is positive is a big exposure risk for any staff or visitors that could be entering your facility. The second looks at international travel. So it asks, have you traveled internationally within the past 2 weeks, which can also be a large risk factor for exposures to COVID-19. And finally, the last one asks, in the past 10 days, have you tested positive for COVID-19, or are you awaiting results of a COVID-19 test? And this question kind of encompasses, or it seeks to catch that general population, maybe a slight lapse in knowledge, where they might think that they're free to kind of go throughout the community at day 5, but we would not ask that they enter a long-term care facility if they're still on days 6 through 10 after testing positive. So this question kind of acts as a catch for that to ensure that we're able to make sure that people who haven't recently had COVID or maybe still recovering from COVID are entering the facility. Next, when people screen positive for these signs and symptoms of COVID-19, both visitors and staff should not enter the facility. Testing may be offered for staff, and if resources are available, it's also, you are able to also offer it for visitors as well. And one thing that can really help with the transparency about reporting different symptoms for staff members could be things like ensuring that leave options are available should they screen positive and need to go home. Kind of as a second to last bit through our symptom screening conversation, we put in something about breaking the routine. At this point in the pandemic, many people have worked through COVID before. We're on year 2, so you're probably used to going through maybe the motions of doing those symptom screen checks. And there are a couple ways that we can maybe break that up to kind of ensure better reporting of symptoms and to make sure that we are getting accurate and complete results every time we have those symptom screening checks. The first is just by engaging your visitors and staff during that symptom screening check. This could be by having a front desk person maybe verbally ask the questions instead of recording them on a piece of paper or taking them electronically. And then additionally asking colorful questions. So verbiage such as, has your throat felt scratchy recently, might connect with someone better than a written sore throat yes/no option could. So these are things to consider to kind of improve that first line of defense against having COVID enter your facility. Additionally, we put this in here as a kind of announcement. This is a communication piece that you could utilize in your facilities just to let visitors know as they enter that you're doing your part in protecting the health of your residents in your facility, and to kind of request that they confirm that they are not sick, that they haven't been in close contact with people, and to encourage things like better hand washing, face mask wearing and compliance, and just ensuring good compliance with the facility's infection prevention and control policies. So this is available in the slide deck that we'll release afterwards, but it could be a useful signage to have posted or something left at the front desk for visitors to look at while they're there. As always, please feel free to contact us at the health department if you have any questions or concerns. Our main number is 703-246-2433, and our emergency phone number for after hours or weekend calls is 703-409-8449. Thank you all so much for attending, and we hope to see you next time on July 1st from noon to 1 p.m. Thank you all so much, and we'll open up to a Q&A section now.